we will record this meeting. Yeah. For the agenda, so I'm going to do a short introduction and look at the terminology of cash and vouchers, because as Anna said, this is mainly targeting nutrition practitioners, and you might not all be familiar with the terminology, so we'll cover that. Then essentially the guidance and evidence note has two main components. The first one is the evidence note. The second one is the guidance note. So the evidence note will be presented fairly briefly, followed by a Q&A, and then with a bit more focus on the guidance note, as well as the recommendations to the nutrition cluster / sector coordinators and nutrition practitioners. Then we will have that session also followed by a Q&A, and we'll quickly elaborate on some of the next steps. So I hope that's okay for you. In terms of housekeeping, please introduce yourself using the chat box. And for the Q&A session, if you have any questions that you would like to raise, please use the Q&A box that you might hopefully that you see in front of you. So please post your questions there if that's okay with you. Good. But before we actually start, we would like to quickly know who you are, yeah? Because as Anna said, just to get an understanding if what is your current profile. So I'm quickly going to launch that poll, and then you can quickly fill it and we'll look at that. So I hope you can see that. So which of the following options best describes your current role? Okay, 5 more seconds. Okay, good enough. So I'm just gonna share the results with you. I hope you can see them now. So we have mainly nutrition cluster / sector coordination teams or coordinators on the call, which is great because that's mainly that's one of the main target groups, and then also nutrition practitioners, which is great, and a couple of cash and voucher practitioners, which is also good, and others might be from other sectors. So good to know. Okay, good. So just as an introduction, I think Anna already mentioned that within the nutrition sector, there has been a growing recognition that cash and voucher modalities can support nutrition outcomes. And in August 2019, I started my role as cash advisor to the GNC with the main task to develop a guidance note and an evidence base for the use of cash and vouchers for nutrition outcomes. For the purpose of that, just for your information, we set up a reference group consisting more than 15 organizations from the humanitarian sectors, mainly with nutrition practitioners that supported my work. So they provided advice, feedback, made available contacts, etc. So that was an important component of that process. And the process resulted in the evidence and guidance note, which I promised to share with you before the event, but I had to break that promise, so apologies for that. But as Anna mentioned, it will be shared, it will be posted on the GNC website next week, and it will be accessible there. The note is based on an evidence and practice review, so a review of peer-reviewed studies, as well as operational examples and projects, as well as key informative interviews. 2 case studies for Nigeria and Somalia, where we paid particular attention to what is happening in these countries in terms of using cash and vouchers for nutrition. And the target audience, as Anna mentioned, is really nutrition practitioners, nutrition cluster coordinators and sector coordinators. So that's really the main target audience, but obviously as well cash and voucher practitioners that would like to get information on how to better integrate nutrition into their programming. Great. So very briefly for the terminology, cash and voucher assistance basically includes the provision of cash or vouchers, so two distinct modalities to target recipients, which can be individuals, households, or communities to access goods and services. Now, it's important to understand that not every time money flows within a nutrition program, that we consider that CVA. So for example, if we pay incentives for volunteers or community health workers or community nutrition workers, we don't consider that as cash and voucher assistance because they are not our targeted recipients, yeah? And they're not selected based on vulnerability criteria. Same goes for payments to institutions, so schools. If we provide financial assistance to school, for example, as part of school feeding, or health centers, etc., we don't consider that as cash and vouchers because they are not individuals, households, or communities. Yeah. It's important here to highlight individuals and households because in general, cash and voucher assistance is usually provided to the household level, but in nutrition programming, often it can also be provided to the individual, targeted specifically to the person that might be at risk of malnutrition. So that's something important to keep in mind. Then a couple of concepts. So in terms of design, we speak about sector-specific cash and vouchers that are more addressing basic needs or kind of needs across different sectors. Often we talk here about multi-purpose cash. So that's an important distinction. Then another important one that we'll come back to is conditional versus unconditional cash transfers. So conditional meaning that the recipients have an obligation to fulfill a certain action in order to be assisted. So they have to do something. It has nothing to do with how the money is spent. I think it's something that is still misunderstood among many practitioners. It's really about having to do something in order to be assisted. And as part of nutrition programs, there's two main conditionalities that we often observe. One is the participation in social and behavioral change sessions. Yeah, so people get assisted, but they have to attend these sessions. And the second one is the attendance to priority preventative health services. So for example, antenatal care, postnatal care, growth monitoring of children, etc. And in that case, people have to actually attend that service in order to be assisted. But we'll come back to that in more detail later. Then utilization, we distinguish here between unrestricted and restricted, although to make it very easy, unrestricted means cash, restricted means vouchers, and of course restricted also means in kind. But again, also among the voucher, we have different design options, commodity vouchers versus value vouchers. In the first one, the commodity voucher, people exchange their voucher against a set package of goods. So for example, 15 kilos of rice and 1 liter of oil and one NFI kit, for example. And in the value voucher actually has a monetary value and can be used to purchase certain approved goods within certain approved vendors. So you can go to certain shops and you have a basket of goods that is available to you, and you can use the voucher to purchase within that basket of approved goods. Yeah, so for example, often fresh food vouchers would be value vouchers, so you can select which fresh foods you prefer. Yeah, so these are two distinctions, and of course, value vouchers offer more choice than commodity vouchers. Yeah. Good, and then in terms of delivery mechanisms, so for cash, cash can be distributed electronically. So for example, mobile money in many contexts, a growing transfer mechanism for cash, but also bank cards and other means, or it can be provided in hand or over the counter. So you go somewhere to collect the money, to a post office, to a bank, or the organization that implements the cash transfer actually hands you the money in envelopes. something that is less and less seen, but still an option sometimes. And then for vouchers, we have paper vouchers and e-vouchers that can be used to do the transfer. And for e-vouchers, there's different technical solutions available. I'm not going to go into detail here. Good. Just Anna, if you spot any comments that say like you don't understand me or something else, please just raise it with me, because I'm not keeping track of the chat box at the moment. Thank you. Good. Okay, let's get started. Evidence note on the use of cash and voucher assistance for nutrition outcomes. And we will start with, as so often within the nutrition sector, with the conceptual framework. And this is actually the updated version that was included in the State of the Children report from 2019. And here to highlight a couple of things where cash can actually play a role or impact, especially the underlying determinants. And the first one is it allows households and individuals to purchase goods and access services that have a positive impact on maternal and child nutrition. So for example, if you receive money, you can go spend that on healthy and nutritious food. You can spend it on hygiene items. You can spend it to access health services, to use transportation to go to the market or to the health clinic, etc. So there's a lot of expenditures that might actually have a positive impact on nutrition. That is reflected here with the green box, and you can also see here at the bottom where the cash lands. So cash for the household it's a financial asset, and it can be spent across these different underlying determinants. Now, if you use conditionality, for example, related to free priority health services, you can actually you can improve attendance to these services. So you might actually have a positive impact on the health underlying determinant. Lastly, the mere fact that the household has more cash can also have positive impacts. Yeah, so for example, the increase in household income can reduce household tensions. It can reduce economic pressures as well within the household. It can enhance decision-making powers of women. It can improve health and well-being of caregiver, etc. So these are all aspects that have a positive impact on care practices and feeding of young children, and also the well-being of caregivers and mothers. So these are the primary ways. As you can see, cash primarily impacts on the underlying determinants. There's a couple of ways that you could also imagine to have a direct impact on the immediate determinants, but usually it's really indirectly in regards to the underlying determinants. Now, very briefly in terms of evidence base, you can see here on the left still the conceptual framework, and on the right the evidence base for the different elements. And the evidence base is not massive for sure, especially within the humanitarian sector, but it is definitely growing. So we can, for example, see that there is growing evidence for positive impacts on child nutrition status, especially for stunting. I think it's more mixed for wasting, and it's not very available for micronutrient status. So there are mixed evidence there, but we'll also come to the reason why we have mixed evidence there. In terms of dietary diversity of children, I think there are more and more studies point to the fact that cash, if coupled with other interventions, and we'll come to that, can have a positive impact on the dietary diversity of children, and also on the health status of children, as we will see when we talk about accessing health services through conditionality, but also just by having more money in the pocket. In terms of underlying determinants, a lot of, or the strongest evidence within nutrition, I think, is for household food expenditure and household food consumption and dietary diversity. So there's a strong evidence that if we provide cash, that has positive impact on food expenditure, food consumption, etc. Growing evidence also on the use of preventative health services, especially when we use conditionalities. Also some evidence and growing evidence for positive impacts on accessing water and accessing hygiene items. Very limited or no evidence actually on feeding behaviors and practices, psychosocial care for children. Some evidence for improved household decision-making of women. Also positive impacts on, positive impacts on intimate partner violence. There's growing evidence there as well. So overall, the evidence base is not bulletproof, but I think it is growing in most areas, and it's definitely, there's definitely some evidence gaps that still exist, but also I think a strong enough evidence base to start to consider cash more routinely in the nutrition sector. Good. Now, an important concept when thinking about the opportunities for using cash and vouchers for nutrition outcomes is the notion of demand and supply side barriers to adequate nutrition. And I will briefly introduce that because it's important also later on when we think about what kind of assessments need to happen and what do we need to consider in these assessments in order to understand what we mean by these barriers, and also then economic barriers. Yeah. So we'll start with the first underlying determinant that used to be called food security. Now it's called adequate food. And I'm just giving you here a couple of examples of demand side barriers and supply side barriers. So for example, on the demand side, at household level, there might be insufficient knowledge and skills on nutritious diets preparation, for example. That might be a barrier to adequate nutrition. On the supply side, there might be insufficient availability and or quality of healthy and nutritious foods in the local market. Yeah. On the demand side also, the markets might not be accessible due to distance, safety concerns, etc. Yeah. There's of course many more, yeah, but I don't want to start to go too deep here. But I want to highlight economic barriers to adequate food here, and that these are the economic barriers are essentially related to the fact that people don't have enough money to access goods and services, or they face opportunity costs in performing a certain action. So for example, to visit the health clinic, you need to take time off that you might not be able to afford if there is enough pressure for you to actually go and work in the field or as a daily laborer, etc. So cash and vouchers can in principle address some of these economic barriers. And here we have a nutritious diet, cooking utensils, and fuel might not be affordable to households, and the transportation to the market might not be affordable. Same logic applies here to adequate feeding and care. Just to give you an example for a demand side barrier, so there might be inadequate knowledge and skills on caring practice and how to prepare a nutritious complementary food. On the supply side, the services that should support caregivers are not adequate. So the counseling services on IYCF, the women's support groups, etc. And on economic barriers, for example, we have preparation of adequate complementary food is not affordable for the children, and the lack of caregivers' time for optimal feeding and care due to economic pressure because they have to work, for example. Same logic applies on the healthy environment. Yeah. So here we also have demand side barriers related to seeking health. So there might be a lack of knowledge of malnutrition or traditional beliefs that prevent health seeking. There might be a lack of knowledge and skills on water, sanitation, and hygiene practices, for example. And on the supply side, of course, health services might not be available or of sufficient quality. Drugs and supplies, therapeutic foods, for example, and equipment for maternal and child health services are not available. So obviously there is a lot of supply side barriers there as well. And now specifically looking at economic barriers, accessing and using health services is not affordable, due to direct and indirect cost. Direct cost might be related to some payments that have to be conducted at the health clinic, and indirect cost relate to, for example, transportation, or when it comes to inpatient care for caregivers, for example, to stay with their child in the clinic, there's indirect cost related to that. The opportunity cost of seeking health and nutrition services are considered too high for the household. Hygiene items are not affordable. Safe water and water treatment not affordable. So a lot of entry points for cash to play a role here. Now, as you see from the two slides, the economic barriers are all on the left side. So the opportunity to address barriers to adequate nutrition through CVA are actually primarily on the demand side. There is some approaches on the supply side, but they're primarily on the demand side. What is important to understand is that in order to determine whether cash can actually play a role, it's important to understand barriers to adequate nutrition in a comprehensive manner. So for example, if the supply side is not working properly for example, for the food market or for health and nutrition services, then giving people money to access a nutritious diet or to access these services is not going to help, because there's nothing to buy, or the services don't exist, or they're not of sufficient quality. So the demand side certainly relies on the supply side, but also the demand side within itself sometimes relies kind of upon each other. Yeah. So one example from the health from health seeking. So for example, if behavioral factors prevent, for example, if there's not enough acceptance of a certain health service for a community to access that, so they don't trust in the health system for whatever reason, then even if they might have economic barriers, just simply by addressing these economic barriers might actually not be sufficient to be able to improve health seeking and to improve attendance to the services. So it's really important to keep all the different barriers to adequate nutrition in mind. And also, the next point, CVA alone is unlikely to be a successful strategy to improve nutrition status of children. As you can see, it's only able to address certain type of barriers. If, of course, in a situation where the economic barriers are the most important ones, and you give cash, you are probably gonna make an important contribution. But it's very likely that you have barriers that are of behavioral nature, that are on the supply side, etc. And their cash alone is not gonna have an impact on the nutritional status of the children. So in principle, it should always be combined with other nutrition sensitive or specific interventions. Cash alone is not a nutrition strategy. Good. Now, very briefly, based on the evidence and practice review, the evidence note identifies 5 main approaches to integrate cash and vouchers into a nutrition response. And these 5 approaches, they shouldn't be understood as standalone interventions, but first of all, they can be combined amongst each other. So and I'll give you some examples later on. And second of all, they can be a component of a broader nutrition response. Yeah. I'm just going to very briefly cover these 5. Yeah. The first one is using CVA for either the household assistance or individual feeding assistance. So CVA can, in principle, be used for both components, with important limitations for individual feeding. On the household assistance level, I think there is, or today, plenty of evidence that CVA actually works in order to, for example, improve food security, improve access to essential goods and services, etc. And when it comes to individual feeding, and by that I mean mainly supplementary and complementary feeding, CVA has a certain, there are some opportunities there, but I think some limitations have to be kept in mind. For example, if for the treatment of malnutrition, we should not be considering cash and voucher modalities to replace specialized nutritious foods, for example. So for treatment, we shouldn't use CVA as an alternative to the in-kind provision of specialized nutritious foods. For prevention, I think there is certain opportunities, particularly when it comes to using CVA to access nutritious foods on the market as an alternative to fortified blended foods and lipid-based nutrient supplements. But of course, that depends on the availability of nutritious foods on the market and whether they can be prepared with a sufficient nutrient density. Yeah. I'm not going to go too much into detail there, that's all in the guidance. One promising approach that was identified in one study was actually combining household cash, so providing cash transfers at the household level to address food security and other basic needs, plus specialized nutritious foods. So that worked better than other preventative strategy in that particular context. And there's plenty of good operational experience with fresh food vouchers for individual feeding. So fresh food vouchers to access fresh foods, but also fortified foods locally available for particular groups. So for example, pregnant and lactating women, in order for them to diversify their diet and have access to fresh foods. This has proven to bring good results in terms of nutrition. Yeah. I'm not going to go too much into detail here. So trying to stay with the main messages. The second approach is pairing household cash or voucher assistance with context-specific social and behavioral change. And here, especially, I think SPC the importance of SPC grows with the growing freedom of choice. So if you give cash transfers, of course, you give maximum choice to the people, and SPC is a way to make sure that the money is actually spent in a way that benefits maternal and child nutrition. And that has proven to be a very good approach in many contexts as a preventative strategy. So the conclusion in the evidence note is that cash and voucher assistance modalities that aim to contribute to nutrition outcomes need to be accompanied with context-specific SPC activities. And that's particularly true for cash transfers. It's also true from my perspective for value vouchers, because also there's a choice element. Is of course, it less applies to commodity vouchers, which don't offer any choice. So it's really, if we aim to achieve nutrition outcomes with cash, either provided at household or at individual level, we should always accompany it with SPC activities. The third approach is providing conditional cash transfers to provide an incentive to attend free priority preventative health services. And here we have a dual objective, because often the cash transfer is actually is calculated based on household basic needs. So one objective obviously is to improve the attendance to these free priority preventative health services, and the other one is actually to provide households with an income that allows them to address some of the expenditures that we discussed before. The conditionality, there's a lot of flexibility in how to approach that. We saw projects where the conditionality was related to the registration at the health clinic. So people had to actually register, show up there for a consultation, maybe obtain a kind of a health card or whatever is available in that specific context. And then that was it. That was the conditionality. And then the cash transfer followed after that for a certain number of months. It can also be tied to specific visits. So you identify, for example, antenatal, postnatal visits that need to be conducted on a regular basis, and you tie the money to the visit. So if people show up for the visit that has been scheduled, then they will get the assistance. Yeah, and also in terms of transfer amount, there was different examples on how to look at that. Some were based, as I said, on household basic needs, but I also saw some that were based on specifically the indirect costs, so just to cover transportation to get to these health clinics. Yeah. There's different ways to go around about that. But of course, if you provide household income, you can have this dual impact that I mentioned. The fourth approach is related to facilitating access to primarily treatment services. So, for example, at referral stage, people are given money or a voucher to cover transportation costs in order to access treatment services. Money can potentially also be paid once they get to the service. So there's also different ways to go about that. And that is seemingly quite a common practice, but very poorly documented. So I wasn't able to extract a lot of learning there, but it's certainly something that is happening. Then also CVA could be used to cover costs related to accommodation and food if the caregiver needs to stay with the child. For example, inpatient care for Sam. That could also be an option. I didn't really find a lot of examples there, but it is an option. Then lastly, the fifth approach that was identified was to provide household cash assistance or vouchers to caregivers of SAM children who bring their child for treatment. There's one particular study in the DRC that finds that household cash transfers actually improved treatment outcomes quite significantly. So it reduced defaulting, it reduced other elements of the treatment. So treatment outcomes were quite significantly improved. At the same time, from practical examples, there seems to be anecdotal evidence for the perverse incentive, which is that caregivers, in order to access the cash, make or keep one of their children malnourished. And this is something that we need to take seriously, but it's not really documented. So there's limited understanding in regards to the scope of that problem, and more research and evidence building needs to happen there. But there is also mitigation measures available for that particular approach. And very important that the risk for the perverse incentive needs to be assessed in community consultations, needs to be included in monitoring frameworks and monitored throughout such programs. I think that's really crucial. Good. So that was very quick. There's much more detail obviously available in the actual note, but that was a quick skim through. And we do have a bit of time for questions and answers if you have any specific questions in regards to the evidence part. And I open the Q&A window and I don't see anything, but maybe if you have anything specific, you can also raise your hand now. Preferably, do I see any hands? I don't see any hands.
There is a
Q&A.
question
Okay.
from Kate, Andre.
From
There is a
Kate.
question from Kate if you saw any difference in evidence depending on location.
Depending on location.
And type of context.
Yeah. I think that's a good question. I think in principle, cash and voucher has a role to play in any context and any stage of the emergency. So I think there's positive and maybe sometimes not positive evidence. I didn't find that positive evidence was concentrated in one particular context. But of course, if you think about certain regions, they have certain nutritional challenges which are common to most countries, and certain approaches might work better. But I didn't see really a clear pattern there. Which countries and regions have generated most evidence? I think, I mean, lot of research was done in Niger, for example, in Somalia. So a lot of African context, I would say, and DRC as well, as some of the Asian contexts, and then on the development side, a lot in Latin America, but I didn't look at that in very much detail. So I was more focusing on humanitarian, and there the concentration of evidence is clearly West Africa, but also Somalia quite a bit, yeah. Then I have a question here: are CVA programs which are conditions to purchase of certain food items not effective nutritionally? So I think what is meant here with conditioned is restricted, and here we're talking about vouchers. So if you want to restrict the choices of beneficiaries, you need to use vouchers. But what the evidence really found is that if you combine cash transfers with effective social and behavioral change, you're actually very likely to achieve the same, if not better, results. Because it's not with vouchers, you're often fairly limited to sectors. With cash, actually, money can be spent a bit more naturally on the different underlying determinants, and you might actually be able to have an impact that you might not have with a voucher. For individual feeding, so for complementary or supplementary feeding, there's not a lot of great evidence for using cash kind of as a top up. I think vouchers might actually be more adequate for the individual feeding. And like I said, the fresh food vouchers offer a lot of good operational evidence, but there haven't been a lot of studies done using fresh food vouchers. Good. Any additional questions? Oh,
there is a question in the question box.
Mm-hmm. The one on voucher are restricted by. So if vouchers are restricted by SPC, can more effective than unconditional cash? No, so I think SPC is extremely important if you do cash transfers, because cash offer flexibility and maximum choice, and that is a good thing in principle. But if you want to achieve nutrition outcomes, you need that money to be spent in a certain way, right? And with SPC, you can influence that. So that's why if you do cash, always couple it with SPC. If you use vouchers, they're by nature already quite restricted. So there you can point people in a certain direction. But then, of course, if people have unaddressed needs that they prioritize, they will just sell the voucher or sell whatever they bought with the voucher. So again, there you don't have full control. I mean, you never have full control in these type of situations. So there in terms of modalities, especially on the household component, I wouldn't worry too much on what is better than the other, because the evidence clearly shows that all modalities have their role to play, and there is no clear path or no clear evidence that one works better than others in all contexts. So what is important is that the analysis is done properly, markets are analyzed, etc. So all the things that we will discuss in the guidance note, and then based on the response analysis process, that the best modality is selected for whatever component, be it for the household component, be it for the individual feeding component. Is there any others? Oh, there's one more. Okay. No. Oh, wait. Yes. What is the reason that the evidence on effectiveness of CVA on nutrition outcomes, malnutrition, is mixed or limited? So, I mean, like I said, CVA can address economic barriers to adequate nutrition, but that's it. So if you give somebody money, and in that context, there's a lot of barriers on the supply side, but also on the demand side that cannot be addressed with cash. Cash alone is not going to help. So a lot of the studies that were conducted, they were providing cash, maybe mixed with, or maybe combined with some other interventions. But that mix of interventions probably was not adequate in that context to address the barriers comprehensively and to lead to changes in nutrition status, for example. Another reason that was often cited is, for example, changes in the disease environment. So, for example, malaria peaks that might kind of evaporate the positive impacts that cash might have on the food side, because actually children were sick and couldn't and reversed the positive impacts. So there's different explanations, but certainly studies that try to look at impacts by simply providing unconditional cash transfers alone, they usually found that it's not really working. Yeah.
Andrea, there is also a question from Chiara in the chat box, and I suggest that the last question we answer, and
yes,
then if there are other questions, people can just type it and we answer it at the end if we still have time. So the question from Chiara is, how would you estimate the number of households who are targeted for other activities purposes, but who also have a child with malnutrition, in order not to select specifically households with a child with malnutrition as part of entry criteria to program?
Okay, so is that a question in regards if we provide household cash not for, and they're using the malnourished child as a targeting criteria? Do I understand that correctly?
Yes, so yes.
Okay. Okay, so the approach 5 that I talked about provided cash transfers to caregivers that brought their child to treatment. Yeah? And I think that is an approach with potential, although, as I explained, there is risks that need to be taken very seriously. If we use cash transfers outside of a treatment program and potentially not necessarily with nutrition outcomes in mind, I would strongly discourage that the nutritional status of children is used as a targeting criteria. I think it's a dangerous idea, and we know that there is anecdotal evidence that it might lead to these risks. So the only approach I see where that can be done is if it's integrated in a treatment response. Okay, sorry, I misunderstood.
Yeah, so Chiara is saying malnutrition.
We could.
Sorry, can you see the chat?
Yeah, again, yeah. Okay, let me just try to.
So she was just clarifying that malnutrition would not be targeting criteria, but it's more one how we would check the overlap between services.
Yeah, I'm actually not sure what is meant by that question. But Chiara, feel free to approach me directly, and then we can maybe have a chat on the phone, if that's okay. Or shall I quickly? Running a bit late. So I would suggest, Chiara, that you get in touch. Yeah, drop me an email. Perfect. Thank you. Good. Okay. So that was the evidence part. Like I said, much more details in the evidence note, and yeah, I know it has 22 pages, but compared to other evidence pieces, I think it's still fairly digestible. And it really, as I said, clusters the evidence around programmatic approaches. So it says, okay, if you do this, like the 5 approaches, it tries to cluster the evidence around these approaches and really identifies things that seem to be working in many contexts. And so I think that is a novelty that in terms of presentation on evidence for cash and vouchers and nutrition. Good. We're going to continue with the second part, which is the guidance note. And the guidance note actually is really focused on nutrition response. Yeah? So the guidance note on the use of cash and voucher assistance in nutrition response. So it's not necessarily targeting a multi-purpose cash response. That is actually part 3 of the guidance, but we're not going to cover that today. So if you have here the humanitarian program cycle, and essentially the guidance note identified identifies 6 main steps that need to be considered in order to integrate CVA in the nutrition response. And these steps are, of course, they are not all encompassing, so they're just looking at the CVA component. Doesn't mean that you don't have to do other things. So the first step is to determine whether CVA can contribute to nutrition outcomes. Second step is to determine the feasibility of CVA as part of a nutrition response, so feasibility assessment. Then step 3, to determine and select response options and response modalities. Step 4 is the design of the CVA component with different elements that need to be considered. Then step 5, implementation, and step 6, monitoring. And then we have some cross-cutting considerations, for example, preparedness, coordination, information management, and risk analysis and mitigation. Risk analysis and mitigation used to be a separate step, but it was included as cross-cutting because it really has to be considered during feasibility, during design, during implementation, etc. Good. So for step number 1, which is determine the potential of CVA, the entry point to this is to look at the demand-side economic barriers to adequate nutrition. That's why I spent a bit of time before to explain that concept. So what does it mean? And essentially, it means, or the thing to look at is to what extent the lack of purchasing power is impacting the ability of households to access and prepare nutritious foods, to access health services, to access safe water, to improve hygiene conditions. So that is really the main focus. And as I said, a comprehensive understanding of all the demand and supply side barriers are required to assess whether cash and vouchers has a role to play, because CVA relies on the functioning supply side and relies on other factors to be actually effective. Now, of course, nutrition assessment tools don't necessarily, they're not designed to primarily understand economic demand side barriers to adequate nutrition, but still there's a lot of tools that offer an entry point to do so. So for example, if you do a barrier analysis or knowledge a CAP analysis, the economic barriers to desirable wash, health care practices can be part of these tools. If you do a SQUEAK, economic barrier to accessing health and nutrition services are actually something that the SQUEAK can look at. If you do an IYCF assessment, economic barriers to adequate feeding and care can be looked at. So it's really, and some of these tools already do so. Maybe sometimes it's a question of tweaking the question as a little bit to give a little bit more, or to add something that specifically helps to identify economic barriers. And then of course there's all the other assessment tools from other sectors that help, because as we saw before, cash mainly impacts on the underlying determinants, and the other sectors of course have assessment tools that can also contribute to an understanding of economic barriers. And two tools I want to mention here, particularly on the food security livelihood side, is the cost of the diet, which really helps you to understand whether people are able to access a nutritious diet and what is the gap, etc. And also the household economy approach. But the guidance offers a bit more, a broader range of assessment tools and how they can be used to obtain a comprehensive understanding of economic barriers. Then in terms of determining feasibility. So feasibility basically means, can we do it? So can we use cash and vouchers? And there's a whole range of preconditions that need to be in place for us to be able to use cash and vouchers or cash or vouchers as modalities. And an important one, obviously, especially for accessing foods or non-food items, is market capacity and functionality. So we need to know whether a nutritious diet can be achieved using locally available foods. We need to know whether goods that are required for adequate water, sanitation, and hygiene are available in the market. When it comes to health, Similarly, we need to understand the supply side. So also here, we need to understand whether health and nutrition services for the prevention and treatment of malnutrition are available and of acceptable quality. And also if we intend to give CVA to access these services, we also obviously need to look at transportation services as well. Delivery mechanisms. So we need to find a way to give cash and vouchers into the hands of the targeted beneficiaries. So we need to understand whether there's a safe and reliable way to deliver cash or vouchers. Community considerations, there's a whole range of things that we need to assess there. Certainly preference in terms of how people want to be assisted, very important. Protection risks and safety considerations. Sometimes people might not feel safe to receive cash, etc. Then how people usually access money, maybe they have bank accounts in certain contexts. What do they do when they have a bit of money? Like maybe they're using already mobile money, so there might be opportunities to tap into what communities are already using. And of course, we need to look at their access to markets and also access to services. We need to look at household decision making. If we provide cash in a household, like who takes the decisions? How will that potentially impact nutrition outcomes? What can we potentially do to address that? Entry points for social and behavioral change communication, etc., for community consultations and dialogue interventions, etc. And also then is CVA or is cash or vouchers likely to contribute to tensions within households or communities? In addition, also acceptance of authorities. So is it actually possible to do cash? Organizational capacity, risks, and costs. Now, don't panic, because I'm sure that many nutritionists will panic at this stage. In 2019, I think $5.8 billion dollars worth of cash and vouchers were distributed in humanitarian settings. So wherever you are, it's very likely that many organizations are already using cash and vouchers, meaning that they have already assessed many of these questions in context that you're considering to use potentially cash for a nutrition program. So it's extremely important that you don't reinvent the wheel, but you look what is available, secondary information. Cash working group is a good first stop for these questions, but also other sectors might have specific insights, food security, WASH, health, etc. So really important that you don't have the feeling that you need to collect all this, but many of this information will actually already be available. And tools are also available to do so. And step number 3, don't see the title here. Yes, so that's response analysis. So determine feasible response options and then select the best one. Yeah. Now, important statement, CVA, so the fact that we might be considering cash and voucher assistance does not change the way nutrition practitioners define objectives or select nutrition response options in order to address identified nutritional needs. Yeah? So that is still the same. Yeah? So the response itself and how you get to the conclusion that you need to run IYCFE, you need to run CMAM, you need to run supplementary feeding, etc. That has nothing to do with cash and vouchers. But of course, cash and voucher modalities, they offer additional ways to contribute to these objectives. Yeah? So CVA adds modalities and how these objectives can be achieved. And in principle, if the analysis shows that there's important economic barriers to the underlying determinants, then the feasible CVA modalities and approaches should be considered as part of the response options analysis. And considering doesn't mean that we're going to use them for sure. It means that we're going to look at them and then decide whether they actually are an important component of the response, or maybe they're not because something else works better. Yeah. So this is an important consideration. But again, I think more detail available in the guidance note. Then when it comes to design, so a lot of cash and vouchers, especially, well, both modalities are extremely flexible in terms of what they can achieve and how they can be designed. And I'm just going to highlight a couple of considerations here. First one is related to targeting. So who should be assisted? Similar to what I said before, the eligibility criteria are largely determined by the program objective and the type of response rather than the assistance modality. So we don't, only because we use cash doesn't mean that we are completely changing our approach in how we target nutritional assistance. I think it's very likely that if we integrate cash and voucher assistance, so if for example, for in one of these 5 approaches that was presented, it's going to follow very similar targeting decisions than, for example, an equivalent in-kind component. Then, of course, if there is certain situations where socioeconomic criteria can be considered on the top of other criteria, especially if you think about household assistance, that would hardly be provided blanket. So there certainly socioeconomic criteria must apply. But for the other things, I think targeting preventative interventions are usually targeted based on at-risk groups, and treatment obviously is targeted towards the people that are sick. So there's no fundamental shift there. Next one is conditionality. We talked about that a little bit, and if you follow the debate a little bit, you might also have heard about hard versus soft conditionality. And so just to explain with an example, hard, like if you have a social and behavioral change activity that requires physical presence, so people have to show up. Hard conditionality would be, if you don't show up, you don't get assisted. Soft conditionality would be, if you don't show up, we will follow up and check with you, and we will encourage you to attend the next session, but we're not going to cut you off the list. Yeah. So these are, and this the same principle can be applied to health services as well. So, for example, if your conditionality is only to register with the health service and to obtain the health card, that is a very different conditionality to a conditionality that is tied to single visits. Yeah. So there's a lot of flexibility here to design conditionality. Obviously, hard conditionality has its price in terms of excluding potentially people that you shouldn't exclude, and also in terms of work that goes into monitoring it. Yeah. So yes, so it should be considered when you can expect the conditionality to improve your the participation in SBC interventions or the uptake of preventative health services, and the expected benefits of introducing the conditionality need to be weighted against the additional costs and resources of actually running it. Yeah. And there might also be a difference here between an acute emergency where you need to respond to needs very quickly and a more protracted one. So in a very acute response, you might actually not be able to invest in a conditionality. It might not be a good idea, but in a protracted situation, it might be better suited. Yeah. Timing, duration, frequency. So I think the evidence is there's not a huge amount of evidence there, but still I think it points in the direction that longer duration, particularly if it's combined with higher cumulative transfer amounts, lead to better impacts, and that's very logical. So I think you don't have to think too much about that statement. Again, timing, duration, certainly the timing and duration will depend on the type of emergency, etc. So it's hard to give any advice that would be applicable in different situations. So programs that used cash and voucher assistance as a safety net response, particularly focusing on the first 1,000 days. So they were providing already assistance to the pregnant women, and then to the once the child was born, to lactating women, and up to the age of 2. These are, of course, not kind of acute emergency responses, but they are responses that were used in humanitarian settings with a safety net logic behind them, and they tend to have good results. I would say, as a rule of thumb, if you consider to use household or individual household assistance or an individual feeding assistance, and if you're considering a cash and voucher modality for either of these components, don't do one-off. So at least 3 months, if not longer. There's really no point in expecting any nutritional outcomes if you provide a limited amount of assistance for a very limited period of time. It doesn't mean that you shouldn't do it, but then don't expect that it will contribute to nutrition outcomes, obviously. Now, expenditure basket and transfer amount. People will be familiar with that. Nutritionists maybe not. So the transfer amount in principle should reflect what recipients are expected to be able to purchase on the local market. So obviously it depends on the objective of the CVA component. If it's, for example, access to a nutritious diet, then the expenditure basket should reflect a nutritious diet. If it's just related to accessing health services, then of course it's going to be a different expenditure basket, etc., etc. So it really depends on the objective. Common expenditure baskets that are used in humanitarian settings are the minimum food basket, which in principle should provide access to a nutritious diet at household and individual level, and the minimum expenditure basket, which goes beyond that, should also include access to a healthy and nutritious diet, but should also provide access to other essential goods and services beyond a nutritious diet. Now, what we often observe in practice is that the composition of the minimum food basket or the food component of the minimum expenditure basket is based on an energy-based diet. So it's trying to reach 2,100 kilocalories by including a limited amount of foods, especially staple foods. And it clearly lacks diversity and falls short of addressing micronutrient requirements. I think that's really a common theme among all the minimum food and minimum expenditure baskets that I have seen. And if you're a nutritionist, as you know, you need quite a significant higher amount of money to be able to access a nutritious diet than to access energy-based diet. So this is really important to keep in mind. Now, the transfer amount, in principle, should reflect the expenditure basket minus whatever the household can contribute themselves to reaching that expenditure level. And just to give you a couple of examples here of MEBs, you see in the middle the one of Nigeria, which actually, if you look at the first two components, basic feeds and condiments, offers quite a big variety from staples to fresh foods, fruits, meats, chickens, etc. So actually quite a diverse diet, yet still not able to fully address micronutrient requirements of average population. Here you have the MEB of Somalia, which only includes 4 items. So again, every MEB is different, and there has so far been rather a lack of clear guidance on how to do that. But in principle, I think if you come from a nutrition perspective and if you want to calculate the amount of household or individual assistance to, especially when it comes to accessing a nutritious diet, but also other nutrition relevant expenditures, then you have to have that as a starting point. Yeah. Now, here the statement on the left, I think, is also quite important because, again, these things like MEBs are essentially existing in practically all humanitarian settings. Yeah. So usually led by the cash working group, there has been a process to come up with an MEB. Whether it's a good MEB from a nutrition perspective or not, I think is a different question. So the starting point for transfer amount calculation for CVA components of a nutrition program should be what is already there. But then, of course, you need to adjust as required in accordance to program objectives. So if you see whatever the calculation is proposing is not sufficient for you to achieve or what you intend to achieve, then that needs to be adjusted, and you need to advocate for that, and probably with your donors. And then, of course, you can also try to influence how these MEBs are set up in order to apply a stronger nutrition lens. So that's why also the nutrition cluster coordinators are encouraged to participate in these discussions. If there is already an MEB in place, then of course often these tools are revised on a regular basis. So make sure to connect with the cash working group and make your point. Good. Step number 5. Implementation. So I'm not going to go into too much detail here. Implementation of cash and vouchers in a nutrition response is exactly the same as implementation of cash and vouchers for any different purpose. These are the main steps. Also, the guidance doesn't go into detail here, but there's a lot of documents that exist that provide detailed guidance on how to go about implementing cash and vouchers. So yes, defining roles and responsibility and aligning them with standard operating procedures within your organization. I think that's important. Putting in place internal and external coordination mechanisms, because you will need your procurement, your logistics, your program people on the same line in order to run these programs, and you need to coordinate externally as well. Beneficiary communication and accountability systems, that is not something specific to CVA, but extremely important. It always needs to be there. Then, of course, you need to have service providers, unless you give cash and envelopes and do it yourself, which is not something I would recommend in most contexts. So you need to have service providers, or in the case of vouchers, often vendors, for the disbursement of cash transfers and the redemption of vouchers. So that needs to be put in place with the right people. You need to identify and register, obviously, and you need to carry out and accompany the distribution. So moving on, step 6 relates to monitoring. Yeah. Again here, at outcome level, so for example, looking at nutrition status, these indicators, they depend on program objectives and they're not tied to the assistance modality. So the fact that you include the CVA component doesn't mean that at outcome level you're looking at anything else. You still want to achieve the same things, just using a different modality or adding an additional modality to your response. One thing that we observed in many projects that come from the food security angle is that they fail to move or they fail to look at the individual level when it comes to food security indicators. So it's extremely important that from a nutrition perspective that you also look at the individual level. So minimum dietary diversity of women, for example, as an indicator, minimum acceptable diet for children between the age of 6 and 23 months, minimum dietary diversity, and minimum meal frequency of children as well. So there's a whole range of indicators that look at the individual level, and it's extremely important that as part of a nutrition response, you look at that and you don't get stuck with household level indicators, which don't tell you really a lot about how the children are eating. Expenditure information is something important to collect because you want to know how the money is spent. And you want to know whether the money is spent on goods and services that are relevant nutrition outcomes. Yeah? So that is something important to look at. And expenditure information can also kind of give you hints at potential pathways for results. Yeah? So how is the cash actually helping to improve nutrition? And also potential unaddressed vulnerabilities. So for example, if you see that a household is spending 80–90% on food, that might actually indicate vulnerability because they're spending such a huge amount on food. Or if they're spending a lot on health, that might actually indicate expenditures related to health events that might really destabilize them. So it can also provide a certain insights into vulnerabilities of households. And then, of course, market price monitoring is important. Risk monitoring. Market price monitoring, again, is already conducted in many contexts, so unlikely that you as a nutrition actor need to set that up yourself. You might need to advocate that goods and services that are important to your program are actually included there. You know? But these mechanisms exist in many contexts. So again, important to check with others. And market price monitoring also important to make sure that the money that you provide is adequate. So if prices increase, the transfer amount should decrease. So it's important to keep track of market prices. Cross-cutting considerations. Now, very briefly, preparedness. Obviously, whatever I said in the last 6 steps can also be done based on identified scenarios. So you can look at feasibility during your preparedness. You can look at markets. You can already contract service providers as required for the response of for certain identified scenarios, etc. So all these things you can actually already do at preparedness stage. Yeah? And what is also important, and I think particularly relevant for the nutrition sector, which is lacking exposure to cash and vouchers in general, is organizational readiness. So, so really making sure that nutrition practitioners within your organization have a basic or have a good understanding on how cash and vouchers work, etc. Then, of course, the partnerships also need to be in place. So if you can be super ready yourself, but if you don't have a service provider that helps you to disperse the money, you're never going to respond to an emergency on time. Coordination, very briefly. So cash is coordinated in cash working groups. Yeah. And these are formally attached to the inter-cluster coordination group, although it's not necessarily in every context that it works out like that. So there's been a lot of different ways that cash coordination has evolved in different contexts. But according to the terms of reference of the inter-cluster coordination group, the cash working group is under that body. So whatever you plan or do in terms of cash, I think needs to be closely coordinated with the cash working group and other sectors. So that's extremely important. And if you use a cash or voucher component as part of the nutrition response, that cash and voucher component should be coordinated by the nutrition cluster and sector. So assessment, feasibility, response analysis, design, implementation, etc., all the different steps. Yeah, if it's part of the nutrition response. So there you also have, and needs to also be reported there actually. Yeah. Information, I just said that the CVA component of a nutrition response should be reported under the nutrition cluster, and there was guidance sent out a while ago on how to approach that, but it's also included in the guidance note. And lastly, risk analysis and mitigation, and very important for cash, not because cash is riskier than other modalities, but because it can really, if you don't take risks into account properly, be programmatic also, being it related to protection risks of communities, and you probably are unlikely to achieve the outcomes that you intend. But important to keep in mind that that CVA modalities are not in principle riskier, and that many risks that we have in humanitarian response are not specific to the modality itself. So you have a lot of risks that actually apply to different modalities in the same way. But important to keep track of these risks and mitigate them to the extent possible. Good. Yes, it took a bit longer than I expected. So what I'm going to do is I'm going to show you a summary of the recommendations, because there's a few more in the actual document, and then we're going to open the floor for additional questions. And I have a couple of polls as well at the end, just to feel the pulse of the audience. Good, so some of the recommendations, and these are specific to nutrition cluster or sector coordination teams, is work with other sectors in the assessment of demand and supply side barriers to adequate nutrition, including economic barriers. Work with cash working groups on CVA feasibility for nutrition response. Support partners to systematically consider cash and voucher modalities and approaches in their nutrition response analysis. Promote adequate opportunities to use CVA modalities and approaches as a component of the nutrition response. And then work specifically with food security on anything that is related to household assistance and individual feeding assistance, as well as with the health cluster when it comes to CVA for improving access to either priority health services or also for accessing treatment of malnutrition. Then support the establishment and revision of minimum food and expenditure baskets and advocate for a strong nutrition lens in these tools. And promotes the documentation and dissemination of lessons learned on the use of CVA for nutrition outcomes. That is extremely important because there's still a lot to learn. There's evidence gaps also identified in the evidence note, and it's extremely important that the learning is properly documented and digested within the humanitarian community. Oh, and the last one, to promote the CVA capacity and confidence building of local and national partners. Good. I'm going to keep it there. And there's more recommendations for nutrition practitioners, but in the end, they point to a similar direction. Yeah. And I'm going to open the floor for additional questions.
So far we have 3 questions and 1 comment. I'm not sure we will be able to address all of them, considering that we only have 8 minutes left. I'm not sure how you want to go about that.
Well, let's maybe take 1 or 2 and then see how far we get.
Okay. So the first one was from Shimvemve. Is there any evidence in differences between giving cash to an individual like pregnant mothers comparing with giving it to household head?
Okay. Okay. So I think as a general rule, it's always a good idea to, within a household, to provide, if you want to achieve nutrition outcomes, to provide the cash to the caregiver. Yeah, or to the in case of a PLW, in case of a pregnant woman, to the vulnerable person. But that decision needs to be based on some analysis, because you might also cause harm if you just give the money to the woman and the man gets upset, etc. So it needs to be discussed within the community. You might want to add a component that addresses some of the risks in your social and behavioral change activities. You might want to involve the man in these discussions, but in general, always a good idea to give it to the caregiver.
Okay, so there is a comment from Regina. I'll read it in case you want to say something, but it might be just a comment. The vulnerability criteria needs to be carefully determined through a very consultative process, with community engagement, with malnutrition being only one of the criteria for selection of beneficiaries' households. It would also be great if you can address the market assessment to determine the availability of food commodities and their prices, to ensure that cash and voucher assistance is beneficial. Also working with market supply system to ensure that the foods are readily available and that cartels don't infiltrate the market.
Yeah, okay. I think one additional element that Common mentioned is really also to look at the supply side, because there's a lot of things you can do to promote the availability of healthy foods, to increase to improve the availability of other services that are required for nutrition outcomes. So that's a good comment. But that's really, like I said, that goes beyond simply CVA, but would then also look at interventions that would support the market. But of course, a very important component of a comprehensive response, yes.
So another question also from Regina, is there learning out there on how to overcome external influence? Cash assistance is very likely to be abused with, in some instances, political influence in some locations, and undue pressure to include certain beneficiaries who are not eligible.
Yeah, I mean, I'm sure there's learning. I mean, that's, for me, that's not nutrition specific. I could point you in the direction of some learning when it comes to cash and abuse of power. I think if you would just Google cash and abuse of power, you would probably get some good resources. There's also plenty of cash and risks, protection risks that you point to in your comments. So feel free to have a look there and approach me directly if you need anything additional.
Question from Christine. Any evidence of soft versus hard conditionalities with regards to impact and cost effectiveness?
With regards to cost effectiveness, no, there is no evidence there. No, I think in general, in humanitarian contexts, I think some of the studies that were looking at these differences, they came to the conclusion that soft conditionality might actually be more adequate, because it doesn't exclude people and it's a bit easier to implement, but there hasn't been any cost effectiveness analysis done in regards to that specific point. Yeah.
So there is 3 more questions from Herman. Let's see what we can answer. The first one is, it will be good to advise on a matrix for context suitability analysis, taking key criteria into consideration, such as market availability and affordability of nutritious food, people preference,
yes,
etc.
No, I think that's common and well taken. I think this evidence and guidance note is not the end of the line. I think there needs to be more investment maybe in practical tools to help some of that decision making. And that will come with time, but yes, I think point well taken.
Are the nutritionists expected to program and operationalize integrated CVA, or to liaise with CVA practitioners for joint programming and service delivery with a nutrition lens?
Yeah, I would say both in principle. I mean, if it's part of the nutrition response, I think the responsibility falls within the nutrition sector. But then, of course, you have a lot of organizations that have, that have cash competency, that have nutrition competency, etc. So, of course, they need to work together in putting in place these programs. That's for sure. But definitely, I think the nutrition sector cannot just say, well, we are going to identify opportunities and then you go and do it. I think that would not be sufficient. No. Then I think part 2 is not covered. Have a look at part 3. Part 3 is not covered. Have a look at part 3, which basically provides entry points on how we could apply a stronger nutrition lens in cash transfers that are not necessarily geared towards nutrition outcomes. For example, if you have, in the context of South Sudan, multi-purpose cash that is being provided, like what could we do to increase our chances that cash is actually contributing to nutrition outcomes? And there's certain things that we can do, and that, of course, would these insights would need to come from nutritionists, but the implementation would happen rather through cash practitioners.
So we have 2 minutes left and 2 questions. I wonder if maybe you can answer them via email.
Yes, I can. I will copy paste them and I will get back to you, Herman, soon. Yeah, and I do have a couple of polls. Please bear with me. Yeah, give me an extra 1 minute just to feel the pulse and also to ask you what kind of support you require. So let me quickly run these polls and please answer. So we have. Okay, the first one is in regards to your level of confidence in regards to considering and incorporating cash and voucher modalities in your nutrition program. It's running, give you 10 more seconds. Okay, I have 15 votes, it's not bad. Okay, good. So I'm just going to show you that. But I'm not sure if it's still the cash people on the line or the nutrition people, because a third of the people feel very confident, which is great. A third of the people feel somewhat confident, and a third feel some, oh, sorry, I think that's a mistake there. Somewhat confident and then somewhat, actually, yeah, the poll was completely wrongly designed. Apologies for that. I'll make sure to change it for tomorrow's session, because it should have been very confident, somewhat inconfident, and very incompetent. Okay, let's forget about that. Let's look at the next poll, which is in regards to what kind of measures are required to increase your level of comfort to consider and incorporate cash in your program. And you can use multiple choice here. Ten more seconds. Okay. So I'm just going to share these results as well with you. So most people believe that, okay, they need to familiarize themselves with the guidance note and CVA concepts. That's great. Training, some technical support and coaching. Need to see more practical examples, okay? And one person says, okay. So I think in terms of practical examples, there's the whole annex of the evidence and guidance note is actually short examples with the description of the intervention and the results that are also then incorporated in the evidence section. But it provides you more detail and provides you with a whole range of different projects and what we can learn from them. So that's a good starting point. In terms of training, there is a lot of training available that is on the CALP website, so that will be a good starting point. But I think also there we will probably in the near future advise nutrition practitioners that are interested to learn more which trainings are most adequate for them. Yeah. Great. So last one, which is regarding the potential of using CVA modalities for nutrition outcomes in your context, based also on what you heard from this session today. All right, 10 more seconds. Still not. Well, obviously you need to do what was described in the guidance note, but I think all of you already know your context well enough to have some idea what I would expect. Okay. So I'm going to share the results with you. And we can see that many of you, or most of you, see a lot of potential, or at least some potential, and some see limited potential. Again, obviously that is context related. So in some contexts, it's much easier to do actually cash and vouchers, and maybe to address also nutritional or barriers to adequate nutrition with CVA approaches, and in others it might be more difficult. Yeah. Okay, that's it from my side. Do get in touch if you have any additional questions. The evidence and guidance note will be posted next week on the website, so have a look, and I hope to hear from you soon, and I hope that it will help you to consider CVA modalities in your work, and to run them successfully if they are adequate response options. So thank you very much. Anna, any last word?
No, I don't want to take more people's time. So thank you very much for your patience and allowing us to be a bit late.
Great. Thank you very much. Okay. Take care, everybody. Bye-bye.